Well, hello, everybody, and welcome to this second of our CMF monthly podcasts. I'm David Wheeler. I'm Professor of Kidney Medicine at University College London and an honorary consultant nephrologist at the Royal Free Hospital in London. And I'm delighted to be joined today by Alan Jardine, Emeritus Professor of Renal Medicine at the University of Glasgow.
If you missed last month's podcast, allow me to introduce you to the CMF, a brand new free educational resource for clinicians. And this podcast aims to keep you up to date with the latest information and data in the field of cardiometabolic diseases. In this episode, we're going to go through a couple of papers published in December 2021 that we think you will find particularly useful and interesting. The first, by CMF Steering Committee member Subo Verna and his colleagues, examines the efficacy and safety of empagliflozin in the treatment of heart failure with reduced ejection fraction, with a post-hoc analysis of the EMPEROR-reduced study.
And in the second of today's papers, Peter Rosing and colleagues examined pooled data from the DAPA-CKD and DAPA-HF studies. Now, these were studies of dapagliflozin that included patients who did not have type 2 diabetes at baseline. And this second paper looks at the onset of diabetes, the development of new onset diabetes in those participants in the trials who did not have diabetes at baseline. This was a pre-specified analysis of the DAPA-CKD and the DAPA-HF trials.
So the first paper looks at the EMPEROR-reduced study. This is a study that looked at patients with heart failure and reduced ejection fraction, an ejection fraction of less than 40%, and showed that the introduction of empagliflozin was associated with a 25% reduction in cardiac endpoints, adding to data that was already available for dapagliflozin and confirming that the SGLT2 inhibitors have significant beneficial effects in this group. For those of you that are not cardiologists dealing with patients with heart failure, there are protocolized treatments for heart failure that have all been established in large-scale interventional studies. So the strategy for treatment of patients with heart failure is one limb, that is to give diuretics like furosemide, and the second limb is a protocolized dose escalation, starting first of all with beta blockers, typically bisoprolol or carvedilol, then adding in a blocker of the renal angiotensin system, either an ACE inhibitor or an angiotensin receptor blocker, and titrating that up to a maximal dose, then adding in a mineralocorticoid receptor antagonist, such as spironolactone or pleuronone. And then in patients who still have a reduced ejection fraction, converting to sacubitril valsartan or Entrestone, and again titrating the dose upwards. It's perhaps no surprise that in such a complex protocolized treatment that not all patients are able either to tolerate all the treatments or all the individual drugs, or that they can achieve maximal doses. And the most common reasons for not achieving maximal doses, apart from intolerable idiosyncratic side effects, are hypotension and hyperkalemia. So in this post-hoc analysis of the EMPEROR-reduced study, the authors have looked at the primary endpoints and a complex secondary endpoint, divided by whether or not patients achieved the intended dose of individual heart failure medications. That was a kind of long way of getting around the, the background to this study. Is that fair, David? Was that the?
Yeah, no, I mean, this is a post-hoc analysis, and I think the real question that they were asking is, did it matter what drugs, what treatments, what evidence-based treatments patients were on at baseline? So the primary outcome in this trial was a composite of cardiovascular death and heart failure hospitalization. And what you see in the table here is the percentage of patients who experienced these events, EMPER versus placebo, with the hazard ratio and the p-value, based on or stratified by their baseline medications. So whether they're on ACEs and ARBs, beta blockers, MRAs, or various combinations here. And you can see here that for some of these drug classes, for example, the ACEs, the beta blockers, and the MRAs, They also looked at whether patients were on more than or less than 50% of the recommended doses of these medications. And the bottom line was it really didn't matter what medications, what evidence-based medications the patients were on at baseline, nor whether they were on optimal doses or not. The benefits of adding the SGLT2 inhibitor empagliflozin were still clear in these subgroups.
So one of the things that's incredibly important in the heart failure trials has been the recognition that hard endpoints such as death are not the only thing that's important in the management of patients, and that hospitalization for heart failure creates an enormous burden, not just in the healthcare system, but also for patient care. And so they've amalgamated these two endpoints in the analysis of heart failure trials. So this is really very important, isn't it? It shows that regardless of whether you can titrate up the individual drugs in the 4 stages of the management of heart failure, that the addition of an SGLT2 inhibitor, empagliflozin, preserves the 25% reduction in cardiovascular death and hospitalization for heart failure. So it's going to make a big impact in the management of patients with this condition.
No, absolutely, Alan. In fact, there was an extended analysis in this paper where they looked at not only the cardiovascular deaths and the heart failure hospitalizations, but also heart failure events that had led to patients being sick, but were actually managed as an outpatient. And when they looked at that extended range of heart failure outcome events, they still saw the same patterns of benefit that they'd seen for the primary outcome of the study.
So these data are shown in figure 2, aren't they? There, or figure 3. I think it's the composite or extended endpoint, which includes escalation of therapy in the community. And again, most diabetologists, nephrologists, and perhaps GPs who are listening to this podcast may or may not be aware that many patients with heart failure are managed by heart failure nurse practitioners in the community in collaboration with hospital services. And again, something that prevents patients presenting with worsening symptoms in the community is a tremendous benefit on the provision of healthcare services. So the analysis of this extended endpoint that includes escalation of treatment in the community is extremely important.
So I think, Alan, the clinical message here is that patients benefit from the combination of therapies. Whatever baseline medications these patients are on, there's still additional benefit from adding in yet another medication, which in the trial was the SGLT2 inhibitor empagliflozin. So we've actually got now yet another medication for patients with heart failure that reduces mortality and heart failure hospitalizations.
So when you look at the guidelines for heart failure, until recently, there were 2 streams. There was the stream that was based on loop diuretics, which is managing fluid overload and pulmonary edema. Then there was the stream, the protocolized escalation of treatment that was based on studies that improved outcomes. So that's beta blocker, angiotensin receptor antagonism, MRA, and then Entresto. And now it seems to me that there's maybe a third line, because it appears that the benefit of SGLT2 inhibitors are, regardless of whatever dose you've achieved in the protocolized management of heart failure. Although I think in the current protocols, they're now 5th line that says beta blocker, block the renin-angiotensin system, mineralocorticoid receptor antagonist to the ejection fraction still low, consider Entresto, and then an SGLT2. But these data suggest to me that you should almost go straight to an SGLT2. Was that the take-home message?
Well, I'm not a heart failure cardiologist. The message I'm getting from my heart failure cardiology colleagues is that we should all do our very best to get patients onto all of these drugs. because there seem to be additional benefits of adding in the next class. And the focus now is on, how quickly we should be getting patients with heart failure onto these medications. How quickly should we be adding in the next medication after we've perhaps added the previous one? Should we be focusing on up titration to maximum dose or getting the next class of medication in? And I think these are all, great questions that we may never answer in clinical trials. But what we do have now is, a number of effective medicines for patients with heart failure. And when we see the patient with heart failure, remembering the poor prognosis for these patients, we really need to maximize the opportunities to get patients onto all of these evidence-based drugs to improve their outcomes.
It is amazing, actually, looking back over the course of our clinical careers, how the prognosis for patients with heart failure has changed in the last 30 years with, large-scale trials that have progressively proven the benefits of individual classes of drugs. And this is yet another, group of drugs that have been shown to improve the outcome.
Sorry, Anna.
No, on you go.
Just to add to that, I remember as a junior doctor being told off for prescribing a beta blocker in a patient with heart failure. I didn't realize the patient had heart failure. But I committed a sin because the perceived wisdom at the time was that beta blockers are going to make heart failure worse because they're going to slow the heart down further and cause decompensation in the context of the heart failure. In fact, exactly the opposite was proven when the trials were done in the 1990s.
Indeed. The question is, how do they work? Do you have any insight into that?
I mean, how do SGLT2 inhibitors work? Well,
how do they work in heart failure?
Yeah. Well, we know, I think we know that there aren't sodium glucose 2 co-transporters in the heart. I think we know that. I always jokingly say to my cardiology colleagues, well, look, you're making the heart better because you're making the kidneys better. And you're improving the patient's ability to diurese, to offload fluid. And as a result, you are improving their cardiac function. But as you know, there's other theories about how these drugs may work, and I don't think any of them have been proven. And I think the honest answer is we're not completely sure why SGLT2 inhibitors have such a large impact in patients with heart failure.
Okay, well, so the take-home message from this study is that the post-hoc analysis of the EMPEROR reduced trial found a reduction of 25% in the primary endpoint that was sustained across all subgroups depending on their therapy that they were on. And the question of how they achieve this, is still to be elucidated. The second study that we've had that David's going to describe to you looks at one aspect of that, which is the proportion of patients who develop who develop type 2 diabetes during the course of the trial. And David, do you want to describe this study?
Yeah, of course. This is a study that actually took 2 prior studies and basically involved a post-hoc analysis of 2 prior studies. So the DAPA-CKD study and the DAPA heart failure trials were sister trials in 2 different populations, patients with chronic kidney disease and patients with heart failure. Both trials included patients who did not have type 2 diabetes at baseline. So remember, dapagliflozin is a drug to treat type 2 diabetes, but these trials actually extended recruitment to patients with chronic kidney disease and heart failure, but who did not have type 2 diabetes at baseline. So in the DAPA-CKD trial, there was 1,398 patients who didn't have type 2 diabetes at baseline, and in the DAPA-HF trial, 2,605 patients. So a total of 4,000 patients who didn't have type 2 diabetes going into these trials. So what this analysis looked at is taking those patients who didn't have diabetes at the start of the study did randomization to study drug, dapagliflozin, in both trials lead to a reduction in the onset of new onset diabetes during the follow-up period in those trials. Now, the definition of diabetes was based on baseline HbA1c levels, and this WHO criteria for obviously the diagnosis of diabetes, pre-diabetes, and normoglycemia. So these were used in the study. And if we go straight to the results here, you'll see that there were fewer cases, fewer events, that is, events of new onset diabetes, in those participants in the two trials randomized to dapagliflozin compared to placebo. And this is around about a 33% reduction in risk. It didn't vary in any of the pre-specified subgroups in this analysis. So it didn't vary by gender, by age, or by any other pre-specified subgroup. So this was a consistent benefit. And what this means, I guess, is that we can add dapagliflozin to the list of drugs that prevents the development of new onset diabetes. And those drugs, of course, include metformin. So the conclusions at the bottom, treatment with dapagliflozin reduced the incidence of new onset diabetes in participants in these two studies. What I should emphasize, because you're going to ask me about mechanisms, is that there wasn't a reduction in HbA1c in these participants who went into the trial without diabetes at baseline. So it doesn't seem that we're just changing the HbA1c and therefore changing the criteria for diagnosis of type 2 diabetes. There was no real difference in HbA1c in these two trials, comparing those participants randomized to dapagliflozin or placebo who did not have type 2 diabetes at baseline.
So the best figure for me anyway in this paper is figure 3, which looks at the cumulative incidence of type 2 diabetes in the patient population. It's interesting, you know, there's maybe a 2% difference overall in the study groups, which is, you know, substantial on a population basis, given the burden for, you know, healthcare services of type 2 diabetes. It looks as though the benefits are seen early on. Was there a reason for that?
Yeah, it's a good point. So the lines there diverge fairly early on in the Kaplan-Meier. Does this tell us something about mechanism? Possibly yes. But I don't have a good explanation as to why this is an early or a late benefit. I don't have a mechanistic explanation as to why this is an early or a late benefit in the study.
And we discussed whether or not there was any impact on weight, didn't we?
There was a separate analysis, certainly of the DAPA-CKD study, looking at baseline weight and the impact of the study drug in those with different baseline weights. And in fact, again, there was no difference in the impact of the drug based on the starting weight of the patient. So no greater benefit in those who are heavier or lighter compared to the other subgroups of weight. So I don't think this is linked to weight and weight loss.
So this is another observation, much like the impact of the SGLT2s themselves on cardiovascular outcomes, where it would be interesting to understand the mechanism, but it doesn't really matter. I mean, this is going to make a huge impact on the burden of type 2 diabetes in patients with comorbidity, and similarly in the burden of cardiovascular disease in patients with heart failure, regardless of the underlying mechanism.
Yeah, I mean, if you look at the paper, the biggest difference, or the biggest reduction, in fact, the patients, let me put this another way, the patients who developed type 2 diabetes during the study were those who had pre-diabetes at the beginning. Those who were euglycemic, those who did not have diabetes at the beginning, were very unlikely to develop diabetes during the study. So this is in a group of patients with kind of borderline HbA1c levels going into the study. And it may be those patients who will benefit most from this intervention in terms of prevention of the development of full-blown type 2 diabetes.
It's interesting. Were there any other points that you felt that this paper highlighted?
I think we've covered it. It's an observation. It's this is what we found. Here's another drug that we normally use to treat diabetes that we're now potentially could use to prevent diabetes. And there may be particular groups of patients in whom, who we want to target with this drug to prevent the onset of full-blown diabetes. Now, I would argue that we're using this drug increasingly now in chronic kidney disease and in heart failure. And many of the non-diabetics with chronic kidney disease and heart failure may well be those who go on to develop diabetes later in life. The conditions tend to cluster together. So, maybe this drug will have benefits in terms of preventing diabetes in these high-risk groups.
I think one of the things that's interesting to me, and it's embedded in this study, is that when statins came along, we thought that they would reduce cardiovascular risk in patients with heart failure and chronic kidney disease. Just under a half, or just over a half of patients in this study were actually on a statin, and the statins were disappointing in this patient group. The GIZI heart failure study, for example, showed no benefit, and yet the SGLT2 inhibitors have shown a substantial benefit in this patient population, both in the prevention of diabetes and the prevention of cardiovascular events. It's a kind of unexpected revolution.
So I think, certainly in more advanced chronic kidney disease, the statin benefit is not as clear. But of course, statins, are drugs that prevent complications of atherosclerosis. And I think the argument is that actually in advanced chronic kidney disease, the cardiovascular disease may not be driven entirely by atherosclerosis. It may well be driven by, hypertension, fluid retention, organ fibrosis, cardiac fibrosis, and so on. And therefore, we should be targeting this structural heart disease rather than the atherosclerotic heart disease in more advanced chronic kidney disease. And maybe this is a drug that does that. Maybe this is a drug that, by doing something to the kidneys to enhance diuresis or natriuresis, we can actually improve the cardiac outcomes as a result.
I realise that we focused on the benefits in this study, but the side effect profile is remarkably good. Is that the case? The adherence to medication was good?
These drugs were well tolerated by patients. Now, I think we should remember that when you start these drugs, there's an acute drop in EGFR or an acute bump up in creatinine, rising creatinine. But we didn't see an increased risk of acute kidney injury in either of these studies in patients who were randomized to dapagliflozin compared to placebo. Sure, you see an increased risk of mycotic genital infection, thrush and balanitis, but these are relatively easily dealt with and don't lead to serious adverse events in the trial. So they don't lead to hospitalizations or death. And then a few other, safety outcomes of interest. Patients may be at slightly higher risk of dehydration when they're on SGLT2 inhibitors compared to placebo, and we need to be careful in patients who are prone to dehydration. And there may be some other effects on bone that we don't fully understand yet. But generally, these drugs were very well tolerated by patients in both of these studies. And as I say, importantly, no increased risk of acute kidney injury.
So just to wrap up today's study, the second paper, which you were an author, shows that dapagliflozin in a randomized placebo-controlled trial, patients with heart failure and chronic kidney disease reduced the incidence of type 2 diabetes substantially. And in the first study, we've shown that empagliflozin reduces the complex compound cardiovascular endpoint of cardiovascular death and hospitalization with heart failure together with an extended cardiovascular endpoint, regardless of whether or not patients have achieved the maximum intended dose of other established heart failure medications. It's very impressive, and I look forward to to further studies in this area. So, to those people listening to this podcast, I hope you've enjoyed it. I'd like to thank you for listening. You can leave a review, and don't forget to register at the Cardiometabolic where you can pick up the documents relating to this podcast and listen to any future episodes. David, have you got anything to add?
No, just thank you to everybody for listening, and thank you, Alan, for the discussion. Thank you very much.